Hello, I'm David Legge. In this presentation, I'm going to be talking about health systems development. I'm looking to take you on a tour of global health systems policy since the Second World War, a little bit of a tour of what you might call health systems science. What do we know about health systems? And then end up with some principles, ideas, generalizations, if you can do such thing, about how to contribute to health system development. I'm being a bit cautious about the idea of health systems strengthening, and you'll come to understand why shortly. I hope you find it useful. Okay, so this is a fairly complicated slide, so let's take it slowly. On the right-hand side, I'm dealing with the OECD or rich countries, and I've listed 5 broad types of health system, loosely speaking, and identified some of the key landmarks in the development of those health systems. So these include then employment-based health insurance, which starts with Bismarck. It goes through to 1942 during the war in the US, and then the 1954 employer tax concessions, all of which supported employment-based health insurance. On the next one is nationalised healthcare systems, which starts with the USSR, goes through to the NHS, to China and Cuba. The national health insurance model, in many ways, starts in Saskatchewan in Canada. It moves then to Medicare, Medicaid in the US, and then moves to Medibank in Australia in 1974. Health systems planning, which is not really a health system, but it's a focus on planning, starts, at least for my purposes on this slide, with 1917 with the USSR. Soviet Union was very into health planning. In 1974, the health systems agencies in the USA were doing a lot of health system planning, structured around the idea of needs certification of needs. And then in 1976 is in some ways the peak of interest in the National Health Service in formalised health system planning. As opposed to the planned development of health systems is the market-based system, although these are not alternatives, not really. And the headlines there are the Kaiser Permanente arrangements from 1939, the HMOs in the 1970s, from the 1970s, and managed the gradual emergence of managed care, DRGs from 1986, and the internal market from 1991, and then Obamacare quite recently. So even though my main focus in this presentation is going to be on health systems in developing countries, I'm emphasizing through this slide the ways in which these different strands of health system development in the developed world, the rich world, have informed patterns of healthcare in developing countries. Okay, let's turn our attention to the left-hand column, where I've listed 7 phases of health system policy regarding the healthcare in low and middle income countries. The first phase is the colonial healthcare systems, providing healthcare solely for the colonists and maybe for the urban elite, based on private practice in the cities and hospitals, which are expensive and only accessible to city people. Now, under those colonial healthcare systems, there was also faith-based mission hospitals, often working in the districts, but not in all cases. Then there comes the post-colonial health systems policy, which is a gradual phase where initially it's simply about continuing to provide healthcare for the urban elite, and in many cases a new focus on developing an indigenous medical profession, which emphasised the need for medical schools and teaching hospitals, and had the effect in some cases of further centralising the resources in the big cities. And in the 1970s, a gradual emerging backlash against the big city, big hospital model with primary health care. And this was prompted in particular by the G77 presence at the World Health Assembly, who were in the early 1970s increasingly demanding that the Secretariat of the WHO provide a more useful, systematic analysis of health systems policy, rather than the fairly benign or meaningless basic health services, which had been the model from 1953. This pressure for primary healthcare led to the declaration of Alma-Ata, which emphasised appropriate technology, community participation, appropriate workforce categories, and most importantly, the idea that it is the job of primary healthcare practitioners to work with their communities to address the social and environmental determinants of health. Unfortunately, Alma-Ata came right at the end of the long boom, and by 1981, the debt crisis was starting to emerge, and the judgment was taken by UNICEF and by Rockefeller that developing countries couldn't afford comprehensive primary health care, and they developed this new model called selective primary health care. In actual fact, selective primary health care was based on just 4 interventions: growth monitoring, oral rehydration, breastfeeding, and immunisation. Later they added female education, food supplementation, and family planning. And this all went under the aegis of the slogan of the Child Survival Revolution by UNICEF. This was a period when UNICEF and WHO had quite frosty relations, because the Director General of WHO at this time was Dr. Mahler, still was a strong supporter of comprehensive primary health care. The 1980s is sometimes referred to as the lost decade because of structural adjustment, the debt crisis, and the destruction, the disinvestment in health systems, which went along with it. I've described elsewhere the way in which the debt crisis emerged, and the way in which many developing countries were forced to resort to the IMF as a lender of last resort, and the way in which it imposed conditionalities under the general descriptor of structural adjustment, which had the effect in large part of destroying health systems. This was becoming increasingly evident, the damage being done to health systems in the late 1980s, early 90s, and the World Bank got involved with its report, Investing in Health, which sought to demonstrate that you can have structural adjustment and develop your health systems if you follow the bank's recommendations. Essentially, the bank was arguing for stratified health systems with different healthcare funding and delivery arrangements for the rich, middle, and poor. For the rich would get private providers and private insurance. The middle might have social insurance and mixed provision, and the poor would get a safety net based on a cost-effective package of interventions. The safety net would be funded through taxation. It might be delivered via public or private providers and funded through public or private reimbursement structures, but essentially it was to be based on a minimum package of benefits. So it essentially was a purchasing model. I should say that the selective primary healthcare model of primary healthcare was really a flawed model. The investing in health was even more flawed, intellectually flawed, and it was never going to work. But it had the effect of resuscitating, of appearing to resuscitate. Well, perhaps not resuscitating, but it was dominant, partly because of the huge amount of money the bank put into it. The late 90s, however, the highlight of the late 90s was the development of highly active antiretroviral treatment of AIDS, and the treatment action campaign, and the tensions between intellectual property protection and access to medicines. And with the macroeconomic, the WHO Commission report on macroeconomics and health came a strong recommendation for increase in development assistance for health. And with this came a dramatic increase in development assistance for health through the Gates Foundation, the Global Fund for AIDS, TB and Malaria, the PEPFAR, the President's Emergency Plan for AIDS Relief. And so the period of the early 2000s was really structured around 100 of these global health initiatives or public-private partnerships, global public-private partnerships, either doing product development or funding vertical disease programs. By the middle of the first decade, it was becoming increasingly clear that these vertical disease programs was actually fragmenting health systems, was causing internal brain drain as the privileged funded programs attracted staff from the general health system, and the presence of hundreds of different donors in the countries produced a huge burden on the health systems. And with this recognition came the new slogan of health system strengthening, which was initially structured around the IHP Plus, the International Health Partnership from 2007, and then the slogan of Universal Health Cover from 2012, which has been strongly advanced by Dr. Chan. So let's review this left-hand column. We've got a series of phases of health system development, from colonial to post-colonial, to primary health care, to structural adjustment, to stratified health systems, to vertical disease programs, and then this return in the late period, in the last 5 years or so, to health systems strengthening. So in the next few slides, I want to go through some of these phases and talk about them in a bit more detail, and we'll start with primary healthcare. The pressure on the WHO from developing countries for guidance on health systems started in the early 1970s. And in particular, one of the players in this process was the Christian Medical Commission, which was a creature of the World Council of Churches, which brought to the attention of some of the senior figures in WHO some particularly inspiring models of primary healthcare from the global south. In particular, the models operating in Solo in Indonesia, the Jamkhed model in India, and the health promotores in Guatemala. At the same time as the senior staff of WHO Secretariat were starting to look at these models, the USSR was calling for a conference. The USSR was keen to show off its so-called Semashko model, using the polyclinics and using felchers as lower level auxiliaries. WHO Secretariat, the Director General, was reluctant to follow to agree to a conference in the USSR, but eventually that conference took place. But to the surprise of the Soviet people, the model which was adopted by the Alma-Ata meeting was very much based on these inspiring models from the global south, in particular the three that I've mentioned. If you wish to follow up these inspiring models from the global south, I recommend a book by Ken Newell called Health by the People, 1975, which is available on the WHO website. So WHO and UNICEF together built a case for a new approach to health policy in developing countries: priority to basic services, appropriate workforce, appropriate technologies, and an intersectoral approach to prevention. The model that, as it came out, in fact borrows from a range of different influences. There was the tradition of community health associated with the CARC, Sydney CARC from South Africa and Israel, the EO community health centres in the US, in particular the one popularised by Jack Geiger, and the Peckham Community Health Centre in the UK in London from the 1920s, were influential in global thinking. The polyclinics and felchers associated with the Semashko model of the USSR was also influential. But as I've said, the radical new models from the global south in India, Indonesia, Guatemala, Costa Rica were very influential, as were the barefoot doctors from in China. The rich countries didn't really think it belonged to them. They thought that primary healthcare was the same as GPs, and they already had GPs. But they may have been surprised by the presence of the NIEO in the Declaration of Alma-Ata. NIEO stands for the New International Economic Order, which was a direct reference to a resolution which went through the UN General Assembly in 1974, which called for a much more called for a reform in the global economic regime, in order to make it easier for economic development for the developing countries. And the reference to the NEIO in Alma-Ata is in the context of recognising how the economic regime globally was a determinant of population health. Okay, Alma-Ata, the primary healthcare, however, has had many meanings assigned to it. And it's complicated, and its value is in fact slightly limited by the many different ways in which people interpret it. At one level, it is a sector of service delivery. It is the sector which provides first contact, continuing, generalist, comprehensive, essential services. In this sense, that people who use the term primary care may be using it appropriately. But primary health care is much more than primary care. It is a policy model for the whole health system and includes a set of principles for service delivery, not just at the primary level of care. And these principles include community involvement, community accountability, community involvement planning and prevention. They include mutually supportive referral systems. So the district hospital is providing support to the local clinics, district health systems properly organised, intersectoral collaboration, a multidisciplinary workforce, appropriate technologies, and essential care. This idea of essential care is now a little bit of an embarrassment to advocates for primary health care, because I think we now think that everybody should have access to effective health care in accordance with their needs. Okay, the third meaning then of this idea of primary health care is its association with social change. The Alma-Ata Declaration recognises clearly the social determination of health. It articulates very clearly the vision of a new international economic order, and offers us a model which includes popular mobilisation working towards health and health development with and through popular sovereignty and self-directed economic development. Primary healthcare was contested from the start. I've mentioned how the UNICEF and the Rockefeller Foundation moved away from comprehensive primary healthcare quite soon after Alma-Ata, and by 1983 UNICEF was full bore pushing for selective primary healthcare, so-called. That was one of the tensions around primary healthcare. Another is a set of questions about the role of vertical programs in health system delivery. I don't think any serious advocate of primary healthcare would say that there is no role for vertical programs, but essentially so that there is a role for specialist cancer programs, specialist trauma, planning for trauma, planning for health promotion, planning for maternal and child health. But the argument would be that the the vertical experts and resources need to be articulated through the primary care sector, the primary healthcare sector. So in my view, the referral relationships and the supportive relationships with various expert vertical programming is a necessary part of primary healthcare. But that's not everybody's view. Linked to that is the question of the power relations between the secondary and tertiary sectors, or with relationships between primary and secondary and tertiary. And this is in part about power relations, and this has been expressed in a influential article by David Werner, who spoke about community health workers as lackeys or as liberators. Are they lackeys in the sense of being employed through and accountable to the health system, or do they have some level of accountability to the community from which they come? So workforce policies remain highly contested in terms of the role of health workers, the role of auxiliaries, the relationships between auxiliaries and traditional health professional staff, and so forth. And the final area of contestation, of course, is the interplay between primary healthcare and the global economic context. Primary health, it's a real paradox that this model of healthcare came into play at the end of the long boom, just before the debt crisis hit, and just before structural adjustment came to really have such a damaging effect on health systems. So I've described in another presentation the way in which the debt crisis arose and the way the debt crisis hit, and the emergence of the IMF as a lender of last resort, imposing conditionalities or structural adjustment on its willingness to make loans to countries which were in debt and which were unable to roll those debts over with anyone else. Structural adjustment included the 6 broad elements listed here. Reduce tariffs to make your imports cheaper. And the assumption there is that the imports are inputs into export manufacturing or export processing, and therefore you need cheaper imports to make your exports cheaper. Devalue the currency in order to make your exports cheaper and gain more export revenues. Of course, devaluing the currency will make imported goods more expensive, and in particular make food more expensive, cutting public expenditure, which is the third dot point here, including food subsidies, health funding and education, will mean that had a big impact on food, on nutrition. Encouraging exports is fine, except that it meant that it was done at the cost of local autonomous development of economic development. Encourage foreign investment, and you may need to deregulate your labour markets in order to do this. And finally, and ultimately, and the bottom line, is pay your debts. So structural adjustment was dressed up as being somehow necessary for export-oriented development, but it was fundamentally about saving the banks, forcing yet again the lenders to pay the full cost of irresponsible lending. This model was very damaging to healthcare. Cutting public spending and making the population generally poorer meant that health systems basically collapsed, and the conditions for health got worse. And so in many cases. And in 1987-88, the UNICEF published an influential book called Adjustment with a Human Face, which effectively was saying that the IMF was inhuman in its approach to structural adjustment. The IMF and the bank and structural adjustment generally at this time were getting increasing criticism, and from the early 90s, the Jubilee 2000 organisation network emerged, arguing for debt forgiveness as an alternative to structural adjustment. The regime which generated these dynamics was starting to be severely criticised, and undoubtedly the entry of the World Bank into global health policy with its 16th World Development Report in 1993 was in part to respond to the critics of structural adjustment. The report effectively recommended that you can have healthy structural adjustment if you do what the bank says. So the bank introduced the DALI, the measurement of the burden of disease, and using the DALI, they estimated the cost effectiveness of particular interventions and recommended on that basis a series of interventions which would be included in a minimum safety net, a minimum benefit package, which would be made available for the poor. Essentially, this is a stratified model of health system development. The bank argued that it should be possible to target funding to these cost-effective interventions, that cutting public spending is not necessarily bad for people's health, that governments are notoriously and inevitably inefficient, that, and I'm quoting here, that a public subsidy for water supply, sanitation and garbage removal is generally not cost-effective, that much hospital care is not cost-effective, and that structural adjustment lending can be consistent with health improvement if you do what the bank says. Minimal, essential, cost-effective interventions for the poor, private sector provision and private health insurance for the rest. As I say, this essentially is a stratified model of healthcare. Private delivery, fee-for-service supported by private insurance, plus out-of-pocket payment for the rich. The middle will be funded through employment, with funding generated through employment-related social insurance, plus out-of-pocket payment, plus with public and private providers. But the poor would get this basic package of cost-effective interventions to be delivered through NGOs, FBOs, faith-based organisations, and perhaps private providers under contract through user fees. It's worth mentioning that if you have private providers in the locality being funded to deliver a basic package of cost-effective products, of cost-effective interventions, the assumption is that they will be charging out-of-pocket user charges for all the other services that they deliver, and they will be in a position to so it's essentially about privatising primary care in a sense. Okay, so as I've described, the stratified healthcare is the model being promoted in the early 1990s, but with first of all the emergence of AIDS, HIV, and then the emergence of highly active antiretroviral therapies in the late 1990s, the tension between access to medicines and intellectual property rights became increasingly a central part of the picture. And this was in particular brought out by the Treatment Action Campaign in South Africa. The year 2001 is a particularly important year, with 9/11 in September, with the WHO Commission on Macroeconomics and Health in reporting in December, in the Doha Ministerial Conference, which gave us the Doha Statement on Trade and Public Health meeting in November 2001. The WHO Commission on Macroeconomics and Health, I've mentioned elsewhere, sought to rework a lot of the ideas which had been present in the World Bank's 1993 report. But in addition, emphasises the threat to this to globalisation. He says globalisation is under threat, is under challenge, and he's talking about the widening disillusionment with a regime which prevents people getting access to AIDS medications, a regime which forces debt repayment in the interest of the banks rather than the interest of poor people, and so forth. So the macroeconomic report of the WHO emphasised very strongly the need for increased funding for development assistance for health, and that's what we got in the early 2000s with the Global Fund, various global health initiatives, and the Gates Foundation. Okay, by the 2007, there was rising criticism of these vertical disease-focused programs because they fragment health system delivery, they are a burden on the officials, they lead to internal brain drain away from general health services towards the vertical programs. But perhaps the most important criticism is that the vertical programs themselves were finding that they do need comprehensive primary health care. That, for example, AIDS patients are not simply recipients of a particular pill. There's a need for diagnosis, for measurement of CD4 counts, for counselling, for treatment of various complications, and so forth, and likewise with malaria. So increasingly, it's evident that without health systems, the objectives of the vertical disease programs are not going to be met. So it's this realization which gives us the rising discourse of health systems strengthening, including the International Health Partnership of 2007 and the slogan of universal health coverage from 2012. Okay, so I'm now going to shift gear a little bit and talk a little bit more about what health system strengthening might mean, or what it has been taken to mean. And on this first slide, I have listed the so-called Harvard health reform control knobs. This is from a book by Roberts, Xiao, Berman and Reich from 2008, which identifies 5 broad control knobs: financing reforms, payment mechanisms, reorganisation, regulation and behavioural interventions, as listed on this slide. So the financing reforms include mobilising funds, pooling funds and methods of allocating funds, and so forth. The other ways, in a very useful book by Peters et al., 2009, he has divided the challenge of health system strengthening, if you like, up into a number of different headings, the first of which is improving service delivery, and he's identified supply side initiatives, demand side initiatives, and other initiatives which don't quite fit into supply and demand, as shown on this slide. And so under the demand side, we've got payment reforms, user fees, vouchers, insurance, contracting out, and so forth. Under the supply side, we've got focus on training, on logistics, on quality mechanisms, and on leadership. And then under other, we've got organisational change, regulation, and so forth. The next heading was by Peters and Co. was improving organisational performance, focusing on the organisation. And here the strategies include regulation, new codes, new laws, human resource strategies being training, team building, organisational learning, management development and so on, input management, supplies, technologies, information systems, and so on. Improving workforce performance has been a continuing theme of this approach to health system strengthening, professional activities, training, budget support, and contracting, and so forth. Okay, I've rushed through these headings because they're all, you can study them at leisure, and I think if you look at Peter's book, the book by Peters and colleagues, you can follow them up in more detail. I want to move, however, from here to a little bit of more philosophical reflection on health systems development generally, because these are very instrumental and in some ways self-evident approaches to health system strengthening. But it might be useful to ask the question, first of all, what is a health system? What do health systems look like? How do health systems work? How do health systems develop? How do you evaluate health system performance, and what kind of principles might we develop for health system strengthening? And this is the way I want to spend the rest of this presentation, really answering these 6 questions, or exploring these 6 questions. WHO in 2007 said that a health system consists of all the organisations, people and actions whose primary intent is to promote, restore or maintain health. So, what do you think about that? Those organisations, people and actions sounds good, okay? I don't think so. I think we need to be cautious about defining a social system on the basis of what we assume to be somebody's primary intent. This definition, by the way, would exclude Big Pharma, the local suppliers, the voters and the taxpayers, whose primary intent is not really about promoting or restoring or maintaining health. They've got other perceptions. The other problem with this definition is that as a system, the system so defined overlaps unknowably with the employment system, the education system, the aged care system, and so forth. The point I'm really wanting to emphasize is that the idea of a health system should not be taken as something in reality. It is a conceptual tool. It is a way of analysing and drawing boundaries within and around our analysis, and we should be cautious about ignoring the relationships between health systems and the context in which they are located, because this is the effect of the boundaries which are drawn by this conceptual tool. So there's a range of ways of classifying health systems. One of the most famous researchers who've worried about classifying health systems is Walter Romer, who in 1991, in many of his publications, explored the classification in terms of entrepreneurial health systems, mandated insurance health systems, and national health services. The next reference I've got here, Mechanic and Rockford, have offered several further classifications. My worry is that that the context which gives rise to an entrepreneurial health system or a mandated health system, insurance system, or a national health service, the context, the rest of the economy, the culture, the traditions, are as important for thinking about health system development as they are in terms of the original development of this particular system. So I think we need to be cautious about forcing unique systems into fixed taxonomies, because it can obscure that which is unique. Having said that, I've got a slide here which discusses health system genealogies, and I invite you to treat this with a little bit of a grain of salt. But what I'm showing here is that there are perhaps 2 main traditions in the developed countries, one of which treats health services as market commodities, free market, with private providers and private insurance, and commonly it's heavily subsidized but likely regulated and referred to as a free market. In red, I've got those systems which treat healthcare as in terms of an expression of social solidarity. And in Germany, the sickness funds gave rise to the social insurance model in Germany, and in the UK, the friendly societies similarly gave rise to eventually to the NHS and its use of capitation payment for general practice. The solidarity model then includes public funding and government provision and public regulation, but it may include private delivery. And more recently, this model has moved towards managed markets. Now, I think it's useful to make a distinction between managed markets and managed care, managed markets and free markets. They're not the same thing. Okay, so the point I'm wanting to make by putting these three different colours on this slide is that the genealogy of healthcare as a form of in the context of development assistance for health has been influenced by these other two, the blue and the red genealogies. So we've described the movement from basic health services to primary healthcare, to selective primary healthcare, to structural adjustment, to stratified healthcare, to disease-centered silos, to swaps, sector-wide approaches, and IHP, and maybe a return to primary healthcare and universal cover. So in some ways, I'm kind of going down the same track as Roma did in terms of classifying health systems, but please don't let the context be forgotten. Okay, so in the next few slides, I want to take you through with a little bit with my tongue in cheek, some different ways of describing the health system. And in this slide, I've got essentially what is essentially a structural description of the health system. This is a WHO building blocks, and WHO says the health system is made up of service delivery, health workforce, information, medical products, financing, and leadership. And these are the goals on the right-hand side of the slide. So this is even more isolated from the context than what it would be if it was just a health system. On the next few slides, I've got some dynamic descriptions of how health systems work. So this is a structural description. These are dynamic descriptions, and they could focus on patient flows, financial flows, information flows, supply and demand, disease treatment, and the logical frameworks. Let's look quickly at some of these. This is a diagram of the NHS from 1991 onwards in Britain, basically showing how patients flow. And the only point I'm making here is that GPs, fund-holding GPs, non-fund-holding GPs treat patients. The patients get referred to the hospital treats the patients. I'm simply using this as a way of pointing to patient flow as a basis for describing how a system functions. This, on the other hand, is health systems understood as the flow of money, and this is the Australian healthcare system, which shows you money moving from the right-hand side of the slide through governments to healthcare providers. So from individuals and injury from the circles here, the black circles, to the boxes here, non-government providers, state and territory government providers, and then governments. So similar flow diagrams can be produced for all sorts of healthcare systems. The point I'm making is that it's another way of describing the health system. This is a health system described as the flow of information, this is a very legitimate form of describing the health system. It's incredibly information intents. The patient goes to the doctor seeking information. The doctor seeks information through investigations. The information is recorded. The management of the records are part of the system, and so forth. This diagram, however, describes the health system in terms of supply and demand, a marketplace where quantity and price intersect and throw light on surpluses and shortages. This diagram describes the health system as treatment pathways. In this case, risk stratification pathways for possible cardiac chest pain. And I'm not going to go into the details of this diagram, just simply to say that the clinical processing of patients with particular problems is another way of understanding the dynamics of a health system. And finally, the health system as in terms of a logic model is shown in this slide. Health systems understood as inputs, funding, planning, so forth, processes, a national plan, outputs, outcomes, and impacts. And this is actually taken from the common evaluation framework of the International Health Partnership. And the point that the logic model here is pointing to is that you need to be able, it's relevant to evaluation, that we need to be able to evaluate inputs, processes, outputs, outcomes, and impacts. The evaluation, I think that my conclusion from this little excursion is that dynamic descriptions of how health systems work are interesting, but partial, and that integrating all these different insights, the structural model, the dynamic models, into a more general description which does justice to the insight these different models throw is effectively impossible. Okay, now we come to how to evaluate health systems, and this is a conceptual framework for health system evaluation used in Australia, and I'm not really sure what the arrows mean on this slide. I suppose that resources lead to interventions, interventions don't really lead to determinants, and I'm not sure that determinants, that disease impairments, yeah, but this is a very useful model. And in this next slide, I'm not going to take you through this in detail, but it's how to use this this diagram to ask questions about evaluating how the health system works. This is another approach to thinking about health systems, and it's about what kind of information we need to make sense of a health system. It may not be the information we need to know how to develop a health system. Well, while we're on health system evaluation, let's look at where this takes you. So on this slide, I've listed, again from Australia's Health, I've listed some of the indicators which are brought forward by that model, the performance indicator system, and some of the trends which are highlighted by the data accumulated in Australia's Health. I guess it's helpful to know whether we're improving or not improving, whether we've got an unfavourable trend in access to elective surgery and unfavourable trend in the health workforce. Yep, that's probably useful. At a more general level, we're more used to using some of these other statistics for evaluating health systems. On this slide, I've compared infant mortality, under fives mortality, and maternal mortality ratios for a number of countries. This tells us infant mortality. The problem, of course, with these kind of statistics is that they reflect both the quality of health systems and also the social conditions which shape health care. But it's of interest to see the dramatic fall in infant mortality in China over the 12-year period from 2000 to 2012, falling from 30 to 12. In Brazil, likewise, falling from 29 to 13. The fact that when your infant mortality is already quite low, you don't get those kind of dramatic falls. Russia falling from 20 to 9. South Africa not falling very much. Argentina not falling a huge amount. And then on this middle brown panel, we've got under 5s mortality, and we don't see the same. We've got some quite interesting falls here. Maternal mortality is a disaster, well, particularly in terms of Nigeria, India, South Africa, and this is significantly a reflection on health systems, although the social conditions like anemia and patriarchy are also playing an important role. On this slide, I've got some comparative data about resources for health systems, and it's interesting to compare the number of beds per 10,000 population, ranging from Russia with almost 100 beds per 10,000 down to Nigeria with 5. The middle panel again shows a very high number of physicians per 10,000 in Russia, quite a high level in Germany, and then falling through Australia, France, Argentina, but still a very low level in Nigeria, India, and South Africa. It's interesting that China and Brazil are standing quite midway between the developed countries and the poorer countries at the top of the list. And then in respect of nursing and midwives, it's quite interesting that Australia stands out as a greater number of nurses and midwives than most of the other countries. But I'm not sure. Yes, so I'm not sure about all these data. I'm not sure about the UK being only 6. Anyway, let's move on. On this slide, I've got total health expenditure as a proportion of GDP and how that has changed over the last 10 years. And you can see that the US has leapt up from 13.6 to 17.7. Brazil's increased quite significantly from 7.2 to 8.9. And China has increased in some degree to 5.1. India has fallen from 4.3 to 3.9, which probably represents a growth in GDP, which has not been matched by a growth in health expenditure. This final chart table shows per capita total health expenditure. So THE is total health expenditure expressed in international dollars. And this is a fairly important slide because it shows you the magnitude of the difference between healthcare spending in India, Nigeria, China, and healthcare spending in the USA. The US spends a high proportion of its GDP, but because its GDP is also high, it means that the total per capita expenditure is extraordinarily high at $8,000 per head, comparing to France on 4,000, Australia on 3,800, UK 3,300, and so forth, and down to China on 423, Nigeria 143, and India. This figure for China, of course, would be very different if you compared the expenditure on the elites in the cities and the eastern cities and the poorer provinces and the rural people in poorer provinces. Okay, now I'm going to change direction again. Oh no, there's one more. table. Okay, this table is about the government share of total health expenditure, which varies from Nigeria at 34% through to UK at 82%, Russia at 60%, China at 55%, South Africa at 48%, government share of total health expenditure, and out-of-pocket share of total health expenditure, ranging from Nigeria at 63%, India at 60%. I'm not sure about this 7.2% for South Africa. Brazil at these data are all taken from WHO's annual statistics report. Russia at 35%, USA at 11%. Some of these data are a little bit surprising, maybe. China at 35%. But it's interesting that China has dramatically fallen in terms of its reliance on out-of-pocket payment from 59% in 2000 to 35% in 2011. Right. Russia has actually increased the out-of-pocket proportion, which is probably a measure of the fall in health insurance, effectiveness of health insurance, because government expenditure on this slide hasn't changed. Okay, so there's some reflections on what is a health system, how to describe health systems, and how to evaluate health systems, and we've taken a few different approaches to that. How do health systems evolve? Right. Now there's some, when there are some very famous stories about how health systems evolve. Bismarck faced social instability in Prussia in 1883 and chose to ameliorate the most dire disabilities of poverty by introducing what has become known as social insurance. What Bismarck did was to say that the employers of low-income people should contribute to the cost of joining up those low-income people to the so-called sickness funds, which were a long-standing feature of Prussian society, but prior to that, they were entirely voluntary. But after Bismarck, the employers had to contribute to the cost of low-income members. This didn't solve the problem of unemployed people or older people, but it was seen as, it stands as an example of social security as an approach to restoring social stability. The NHS is a very famous history, and I've highlighted 4 dates here: 1948, 74, 82 and 91, where major reforms were undertaken. The Australian Medibank is considerable interest, particularly for Australians. In the USA, I've highlighted 3 presidents who were particularly, 2 of whom were particularly influential and 1 of whom failed. Johnson, Clinton and Obama. Brazil and Thailand I've mentioned. These were both countries which lived under military rule for a long period, and as part of the struggle for democracy, the struggle for universal healthcare came out of that struggle for democracy in both countries, and the dates that I've highlighted are significant in those struggles. And then finally China, with its histories of the first barefoot doctor model, and then the collapse of the primary healthcare model from 1978, and the gradual rebuilding of primary healthcare in China, the struggle to rebuild after 30 years of collapse. Okay, so I want to, in the next few slides, I want to make a single point, but I'm going to make it across time, of the importance of contingency. So in this slide, I'm comparing Australia, the USA, Cuba, and Brazil. I'm taking Australia and the USA as examples from the rich world. I'm taking Cuba and Brazil as examples from the poor world. I'm taking Australia and Cuba as examples of comprehensive and universal healthcare. And I'm taking the USA and Brazil as examples of multi-tiered systems with a public safety net. And in each of the boxes here, I have listed under 5 mortality in a row across here, total health expenditure per capita, government GDP per capita, government proportion of total health expenditure as a proportion, and the Gini coefficient, the measure of inequality. So on this slide, Australia is the least unequal society and Brazil is the most unequal society. These Gini figures are, I'm not sure how reliable they are, but they're the best I could get for these 4 countries. Okay, so what we find is that for a much higher GDP per capita, remember I said in the previous slide that the USA was spending $8,000 per head out of their GDP per capita of $42,000. They get an under 5's mortality of 8 per 100,000 compared to 5 for Australia, 7 for Cuba, but 116 for Brazil. This 116, I have to say, is falling, but it's still very, very high. Okay, now in the next few slides, I'm going to summarize some features of the histories of these 4 countries, which I think helped us to understand the structure of their health systems and the reason that they have got these statistics. We'll start with Australia. I'm suggesting on this slide that the early affluence in white settler Australia was linked to imperial preference. In other words, Britain gave the members of the British Empire preferential access to the British market, which meant that we were able to sell wheat and wool into Britain, which led to what's called the wage earners, helped to pay for the wage earners welfare state. Because we were getting preferential treatment from the empire, we were able to maintain relatively high tariffs, which protected the development of local manufacturing, but it also meant that we, in various ways, that we developed this a more or less collectivist ethic. Now, the collectivist ethic probably came from being dutiful convicts, and as well as this issue of imperial preference. However, this model unravelled from the 1970s with globalisation and the decline of the British Empire, widening inequality and thinning out of the welfare state. But the health system model that we developed from this history is tax-based, has a single payer, and has universal health insurance. Now, I've rushed through this history and perhaps I haven't done it justice, but the point I'm wanting to make is there is a particular history behind our tax-based single payer universal health insurance. In the US, slavery was a very important contribution to wealth, particularly in the South, which means that the institutionalization of inequality, both in the economic structures and in the institutional norms and culture, was a very strong feature. It was a resource-rich and very diverse continent, and capital was gradually accumulated from the domestic economy, including human capital from massive migration, The US in the latter part of the 19th century developed an imperial relationship to Latin America and developed a revolutionary need to separate from Britain, which may have contributed to a certain hostility to government, to authority, which may have been associated with the sort of frontier individualism associated with the gradual move to the West. The point I'm wanting to make is that the entrepreneurial healthcare model, the sort of fragmented, marketized funding, the lack of support in the US culture for universality is related to this history. You may wish to tell a slightly different story, but I think you'll find that whatever story you tell, this hostility to government, the fragmented, marketized funding, the lack of concern about inequality, and the reliance on entrepreneurialism is embedded in that history. Brazil, modern Brazil, starts with a white settler elite, with slavery and massive indigenous oppression. It's a country with natural resources, but it also builds its wealth on the exploitation of slaves and indigenous people. And so its wealth is tied to this inequality and a fiercely contested polarisation. It is this polarisation that the 1988 Constitution was seeking to redress and still is. But according to this argument, the history of Brazil it can be seen as being really very emerging out of this unequal economic inequality with unequal mixed healthcare provision, strong social insurance for the rich and for the middle class, but strong popular support for a universal primary healthcare, but as under the 1988 Constitution, but facing a huge job with such massive inequality. And finally, Cuba, which was a white settler regime with slavery, but widespread inequality led to a revolution in 1959, which was followed by aggression and sanctions and covert destabilization by the USA, which led this country to be on an emergency war footing, in particular after the collapse of the Soviet Union in 1989, which led to and entrenched a planned approach to healthcare and to improved health, tax-funded, publicly provided through a national health service, ensuring the most efficient use of human resources possible, which is why Cuba has a better child mortality rate than the US. So there's my 4 countries, and the story I'm trying to tell is that the health statistics reflect the histories. So Cuba, with total health, with a total per capita GDP of 3,900 compared to 42,000 in the US, has got a better under 5s mortality rate. Brazil, with a similar history of slavery and white settler colonization, but has not had the revolution and has not had that long period of semi-war footing, has a not such good outcomes in child mortality. Okay, let's follow up this idea of contingency a little bit further. And on this slide, I've got a fairly clumsy heading, I'm sorry. It's about how shall we frame the relationship between health system development and the wider social, economic and political context. And we've discussed contingency as a way of framing that. But in the next few slides, I'm going to discuss contingency and path dependence, convergence and serendipity as different ways of understanding this relationship between health system development and social development more generally. Let's start with contingency. I'm using the term contingency to refer to the ways in which the history, institutions, values, culture, politics, economics shape the ways health systems work. And the clearest example is the kind of collectivist ethos in Australia compared to the frontier individualism in the US, and the way in which those different value constellations have shaped health system development in those two countries. Contingency also includes individual people. It includes the fact that somebody was present at a particular place and a particular time, or they weren't, because people can make a difference. Now, contingency is closely related to the idea of path dependence, which is to say that what happens will be dependent on the previous path which has been taken. What will happen is shaped by what has gone before. So path dependence is usually taken as referring to previous health reforms, that if you do one health reform, let's say you, in Australia in 1922, there was a big dispute between the AMA, or BMA as it was then, and the friendly societies, which had the effect of breaking the dominance of capitation payment by the friendly societies to general practitioners. Now, path dependence tells us that once that had happened, we were never going to go back to capitation, whereas a battle of that sort didn't really take place in England, which meant that capitation was established from 1911, and in 1948 capitation became the basis for payment of general practitioners. So path dependence is talking about health reforms which have gone before, or health system changes which have gone before, and contingency I'm using to describe the bigger picture. Okay, but the opposite of contingency and path dependence is this idea of convergence. And convergence is an argument which says that the ways in which health systems are developing is increasingly common. And I've listed on this slide three factors which are common across many different countries. One is the constraints which exist on resource mobilisation for healthcare. So, although these constraints are different at different levels of economic development and are different according to different employment patterns and therefore tax possibilities. So in countries which don't have, which have a large informal sector, it's much harder to establish income tax as a significant tax mode. Whereas in countries with formal employment generally, income tax is the standard. Okay, the second driver of convergence are the cost pressures and the need for expenditure control. And this is the case whether you're talking about public financing, in which the expenditure, the imperative of expenditure dynamic is impacting on government, or social insurance, where it's the employers who start to jack up about the cost pressures and expenditure control, or out of pocket, in which case it's the public. In whichever case it is, the need to achieve, to find mechanisms for controlling healthcare expenditure is common. However, if the expenditure control is in the public financing system or is different from the private financing system, is different from out of pocket. So the way in which these pressures will be felt will be different. And finally, the relationship between equity, illness protection, universality, and is a common factor which is driving convergence. However, this is modified by inequality. So in situations of gross inequality, it is harder to maintain a culture of social solidarity, which is necessary for the pooling of funds needed for universal health cover, for illness protection, and for the transfers to achieve equity. And it's going to, the capacity for building these transfers in is going to depend upon what has gone before in terms of private and employment-based insurance. Okay, but the third way of framing this relationship between health system development and the wider social context is serendipity. In other words, luck. In other words, chance. And you'll often hear people refer to windows of opportunity, or the lining up of the planets, or the conjunctions of the stars, in terms of whether a particular option for health system development is picked up and implemented effectively or not. And this often will depend upon having individuals who are ready to grasp the opportunity or not. So here are three different ways of understanding how to think through the relationship between health system development and social development generally. But there are other ways of looking at it. For example, we can look at the forces of change. And on this slide, I've made a contrast between understanding the forces of change in terms of institutional interests and in terms of class interests. In many respects, in many respects, the way the health system develops is a reflection of the interplay of the doctors and the nurses and other professions, of big pharma, of the marketing of electronics and plastics, of the influence of local suppliers, of the influence of insurers. In other words, of the interplay of institutional interests, what Sidney Sachs called a strife of interests. However, when it comes to healthcare financing, class interests also play an important role in that if you've got this wide inequalities, then the rich are less likely to be willing to pool in order to effect transfers to support the poor. The union movement, which presumably reflects the interests of employed but lower income people, has generally been in favour of universal health insurance and single payer models, because it is in their class interest to be so. So, and the same thing goes for resistance as well as driving change. So we need to think about that. So now I want to return to health system strengthening, and the way I'm wanting you to think about health system strengthening is that it emerged in response to criticisms of these vertical disease focused programs. My concern about it requires that we understand it in that context, that the donors were being criticised for their vertical programs. They were being criticised for damaging health systems, and therefore the discourse of health systems development emerged in the donor discourse. So my criticism is that the health system strengthening discourse continues to take the subject position of the donor officials and the outside experts talking to national officials. In other words, it is a way of looking at health system development, but largely from a donor perspective. And this is a donor perspective which focuses on the levers available to the donor officials and to national officials. It tends to avoid politics and to avoid the structures of governance of which the officials are part. It tends to discount the experience and aspirations of other stakeholders and not to recognise their agency except as barriers to be overcome. It treats people as objects with incentive engineering, which makes it harder to harness their good faith. So it's very much it tends to have a top-down perspective. The donors need to be looking at a national strategy, and they need to be able to see what are the national priorities, where will we make our contribution, and this is part of the so-called SWAPS model, this sector-wide approach. That to implement a sector-wide approach, we need a national strategy, and we need negotiation among the donors about who will do what. Who will do what among the donors? It doesn't really recognise domestic politics. It doesn't recognise the agency of the professionals. It is the agency is focused on who will do what within the sector-wide approach. So my experience, however, and my reading of the history of health systems suggests to me that domestic politics actually drives incremental change around a wide variety of priorities in very specific circumstances. It is therefore important in thinking about health systems development to think about the domestic constituency, about creating a conducive policy environment. Let me explain in more detail. Think about health systems development in terms of a sequence of periodic policy interventions between which there is a process of unplanned development between those episodes of reform. So there is at a particular point in time, there is a certain institutional unfreezing, that new possibilities for change emerge, a window of opportunity for change emerges. And incremental reform may emerge out of a combination of a consensus about where we should be going and the contested objectives of partisan advocates. This is the strife of interest. However, between these periods of policy reform, we have unplanned development, which may be progressive organisational development or even organisational degeneration, the emergence of new bottlenecks and new pressures, the emergence of new technologies which stress the old institutional arrangements, epidemiological change such as the emergence of chronic disease, and demographic change, in particular ageing and the changing needs of ageing populations. So I'm suggesting we think about health system development in terms of dispersed incremental change. That health system development takes place incrementally, that these incremental developments are often dispersed across time, across level, and across sector. You'll never be absolutely sure where they're going to take place next. That the opportunities for incremental change can be created but often arise unpredictably, and that what is possible in each episode is determined by what has gone before. And therefore, health system strengthening or health system policy reform depends on the success, the coherence, and the sequencing of these incremental episodes of reform. The success depends upon the setting of each episode, the coherence and sequencing can be guided by a long-range vision. So where I'm trying to go with this story is that leadership and readiness and vision are really quite critical to managing the opportunities for change which come and go. So resistance to change ebbs and flows. This is another way of saying that institutional structures freeze and unfreeze. That you need to seize the moment, choose the issue, and be ready with good ideas in your top drawer. We need to build constituency for change and to create a conducive environment for change so that when the opportunity arises, you are ready to drive change. So what can we say about creating a conducive policy environment? We need to build a constituency for change. We need to work with the people who have most to gain. We need to work with the practitioners who care about the communities who have most to gain. We need to support a sustained and inclusive policy conversation so that we are ready with the best policy ideas when that window of opportunity opens. We need to build policy capacity to cultivate policy research so that we are generating these best ideas. We need to develop leadership in government, industry, academia, and in the community, in the social movements. And we need to build consensus around a vision for healthcare. A vision doesn't require that we know what the next step is, but it knows where we are trying to head. We should also recognise that political culture shapes whether you can do these things. This approach to building a conducive policy environment assumes basic freedoms. It assumes institutional norms of integrity, accountability and transparency. The critical principle for practitioners and activists is to be ready for the window of opportunity, to continue to review possible scenarios of change, to continue to develop and rework practical policy options, keeping the best options in the top drawer, ready for the opportunity, to keep your constituencies primed for action, and to keep communication channels open through which you might communicate a particular policy option. I might end with this last slide, which is about a partial stories approach. I think I said at the beginning that understanding the health system is impossible. That we need to approach it with a partial stories approach. There's many problems. Each problem has got complex origins and complex interconnections. We need to focus on the priority problems, to describe and explain them from their immediate to their root causes, to think about both structural and historical understandings of those root causes, to trace from root causes to diverse consequences, and to develop policies to solve priority problems. Policies which will address root causes as well as immediate causes, and policies which we develop while checking their impact on other priority problems. The concept of a single overriding strategy for change which determines what will be done by whom doesn't tally very closely with the way health systems develop. Okay, then there's a slide which contains some of the references I've referred to, and finally a slide about discussion starters. How shall we structure a useful discussion? I've spoken about the flow across time of different health system fashions: comprehensive primary healthcare, selective primary healthcare, disinvestment, stratified health systems, vertical disease programs, and now health system strengthening. So are you happy to locate these changing policies in their geopolitical contexts? Because this is what contingency is all about. What do you think about this idea of health systems not being real? Health system is not real, it is a conceptual tool. What's the meaning of contingency in relation to health system development? What's the meaning of path dependency? Can you discuss the interplay of serendipity and strategy in health system development? I'm really looking forward to having these discussions with you. I hope this presentation's been useful. Cheers for now.